All right. Man, X gets on that stream quick. But I think here we are. Let me know, please, if I have audio. That's been something I'm not as good at, but I see bars moving, so hopefully that'll be the win. We're going to try a little different strategy for using the chat today. I got Dr. Ginny is going to help me out. If I can get the chat going, let's see. So far, it's not happy with the chat, so let's see. What's Restream have to say about it? Okay, looks like we're good. Oh, look, I have a crown. No audio. Awesome. Oh, good. Actually, let me see here. I didn't know I could do this. I'm gonna try to pull this restream out over here. Cool. So now I can see chats everywhere. Great. Awesome. Sorry for that. Thanks for letting me get rolling here. And we are live on Facebook. We are live on YouTube. We are live on X. We don't have Instagram running tonight. Sorry about that. If you prefer to watch it there, let me know. But otherwise, we're going to get going. Take some questions today. Okay. All right. So, yeah, we're going to be off and running. It's been a good week. Hopefully, you guys are enjoying your summer. We've had a fun week so far this week, and I actually thought we'd ask some questions, and then I wanted to share just these two little kind of reminder pieces for everybody, just because I know a lot of people are here every week, kind of in the hustle, trying to figure out what to do, and yeah, so I thought just some things maybe just to help people kind of in the hustle who are working toward health, keep on their plans. Okay, let's see here. I think I have the ability to pop these in. Hello, everybody. Hello. We got Dr. Marcico, Denise Clark. Glad you're here. Susan B, Matheson, Amanda, Eileen. Hello to everyone. I was trying to see. I actually have my chat. I'm seeing it through. Restream here. But I can't bring them up on the screen. I know. I was looking at my hair, Eileen. It's all over the place. Claire likes it long. I have a hard time dealing with it being long because I'm used to having it short. And every time I look up, it looks like I just went through a blender. So that's the way we do it. But anyway, here we go. Irene, welcome. Matheson wants a spinning chair update. And how are you planning to pimp it? Yeah, so we got our other chair in. It's doing great. Everybody should be pleased and happy. It's running well. We're able to do some fun things with it. We haven't been able to pimp it out yet. We've still got some tech that we're working on. I have a good friend who is a distributor. His name's Matt Behrens, and he is working on getting some add-on equipment for me so that we can make it even better. I'm going to keep that under my hat until we figure it out, so we have it. Barrettes, that's what I need. I need barrettes in my hair. If we get to the point where I gotta wear barrettes, my wife is gonna be sad, but I think we will have to cut it, and that's where it will go. So I'm gonna try not to look at myself in the picture. Okay. So I wanted to share just real quick as we get rolling, everybody finds their way in. Just quick, 2 papers, really easy stuff. But we have had some conversations about, I don't know if you guys remember, we did a live stream with Keith Cronin of Neuro20, and we use the Neuro20 system in our office for certain cases. And in those cases, one of the things that's really interesting is the response of cerebral blood flow, the responses of CO2 responses that come with that, and then overall being able to kind of feel our bodies at a better rate. And so there's these two research articles that came out. This one's from June of this year, so just happened. It's a early release, but it says it's the clinical efficacy of neurofacilitation technology combined with rehabilitation training based on cerebral blood flow velocity and cerebral metabolism. And in this particular one, the study was done in children with cerebral palsy. And so this just really speaks to us, because this idea of, is a fancy word, but neurofacilitation technology is like we're talking about with our neurotraining system, where we've got the ability to stimulate muscles as we are doing activity that increases the level of feedback to the brain, so the brain's able to do more by amplifying the signal, which is super, super cool. And I just wanted to call attention to that, because while I know a lot of people that are on this stream aren't necessarily people with cerebral palsy, the correlate is that obviously cerebral palsy is a neurological disorder. It's a neurological disorder that is typically, we're dealing with an at-birth trauma where we're causing a stroke or ischemia within the brain, and is considered to be permanent, right? So not a lot of upside that's usually attached to that. So our people that have other types of ischemia, things like POTS, things like functional movement disorders, concussion, PNES, this team of people should lean in on this, because what it shows is that cerebral blood flow velocity and cerebral metabolism indicators can be key factors in the construction of a predictive model. What does that mean? It means that in these cases, they were able to find that we had improvements in these children, 259 of them, so not a small number, where they were doing things like putting them in these assisted suits where we're getting more stimulus through the body, and that allows them to be able to drive more signal to the brain. And we see changes and improvements in cerebral blood flow and cerebral metabolism, which is super, super cool. So kind of a really nice research synopsis of a thing that we see clinically all the time, but it's always nice to see that published, see other people seeing what we're seeing. So I'm really happy about that. Nomad Over Normal said that, okay. They checked in with Keith, he answered. Keith's a great guy, I love him. We actually just spoke with him a little bit this afternoon. And then the second one I'm gonna give you is a very similar. So it's like we're triangulating. So we just looked at one that's like an early in life scenario with cerebral palsy. Here is a similar idea where we're looking at functional electrical stimulation assisted cycling. Say that 3 times fast, I dare you. On perceived effort, which means like how hard they feel like they're working, cerebral blood flow, thing we like to talk about, and cognitive measures or cognition in post-stroke patients. And so if we think about that, here's like another brain or cerebral ischemic injury, or it can be hemorrhagic injury, but basically we're affecting the blood flow to the brain for a period of time where it's going to cause an injury. When we have that stroke, obviously those tend not to be things that we're excited about. But in the post-stroke patients, we're seeing that this is a lower number of people that were applied. This is 15 patients, so not nearly as many, but they reported a lower perceived effort when they were doing this stimulus. So what they're doing, same kind of idea, different model, but same idea where we're applying an electrical stimulus while doing an active rehab, in this case cycling. They're doing it on a cycle ergometer where they're seated, kind of like a new step machine if you've seen one of those. We may do it in all sorts of different ways where we may be laying down or on a tilt or whatever that is, but they're finding that it feels easier, right? So we like that. And then they were able to increase their heart rate. They were to increase end tidal CO2. A lot of you that have been in the office know that that's something that we get really excited about, because if the end tidal CO2 stays in that nice functional range between like 35 and 45, we're kind of priming the brain for maximum fuel delivery throughout the system. So we're able to push that blood through, flush it in, and allow as much blood to flow through that brain as we can given those constraints. So pretty cool. We also see increases in cardiac output. We see improvement in cerebral artery blood flow velocity, and then also higher blood lactate levels after this type of cycling, which is really, really cool. And those of you that have seen this in action know how effective it can be. But again, this was just another kind of just a little bit of what's the word I'm looking for? Like someone else that is supporting the things that we are doing, seeing it in a different place. You can see up here, this is in France. The other one was in, where are we at here? Shenzhen, China. So we can see around the world that people are kind of cluing into this, which is super exciting and lets us know, like, number one, we're doing a thing that other people are seeing benefits from as well, but then also we're seeing the spread of this information, which is just awesome. So I'm super happy. Dennis H was asking, I was hoping I was going to be able to pop that into the view here, but I guess I can't. Is there a way to measure CO2 at home? I have dysfunctional breathing patterns. Any devices? Chronic hyperventilations, and I think that's been a trigger. So things you can do at home, that's a little bit tougher. So a thing to think about, those of you that are dealing with kind of disrupted breathing patterns, can be relative to a way we're feeling, can be because of a central pattern generator. But ways to address it at home, a lot of people will find that some form of meditative or paced breathing is helpful. But also, if you're already having some errors in the breathing, a lot of people can actually feel like it makes them feel lightheaded. They can feel a little bit worse, oxygen hunger. And it's hard to know if that feeling is one that you should be running toward or running away from. So we use end-tidal capnography, or measuring the CO2, as a way to give some biofeedback about like where we're at in that range. And it may not be specific to breathing. It may be because of pH changes in the body. It may be because of cerebral perfusion difficulties, and that is the compensation that happens. So there are a lot of different ways it can happen, but generally speaking, we try to get people to not just modify their breathing patterns, but to actually increase their metabolic demand of oxygen. And with being able to increase the metabolic demand of like using the muscles, we have the positive benefit of being able to create CO2 within the system. And as we do that, it's going to allow us to be able to dilate some of the peripheral vasculature and allow that blood to flow easier and allow us to be able to make those changes within the brain. So it's counterintuitive, but being able to actually find a way to stimulate the muscles so that they're generating metabolism for many people can be a good way to drive this system. We use end-tidal capnography. I don't know if that's available in a non-clinical way. To be honest, I just don't know. But that can be a really useful tool if you have access to it. I'm not sure to what degree you're supposed to get those if you're not a physician. I just don't know. Let's see. Can you explain dissociation versus seizures? What do they feel like, or how might one know which they are experiencing or where to go? Okay, well, that's a good question. So dissociation is a feeling, right? So I can't look at someone and say, you know what, you're dissociated right now. You might be able to describe a feeling that you have, and I might infer that that's what you're experiencing, right? But a dissociation classically is going to be what someone will experience when they don't feel like they are connected to themselves, when they don't feel a part of their body. They may not might feel like my head is floating, or I'm not inside my brain, or it's hard to be able to connect to myself. And in these cases, a lot of what we tend to look at is how we're able to deliver fuel to the area, and then how that is then going to influence the functioning. So we may see that it's not just fuel related. It could be related to an injury or a trauma within the system that causes malfunction within that functional connection where we see the brain isn't able to generate that sense of self that we experience. There's this really good book. I don't know if you guys have read it or not. Now it's going to escape me as soon as I think of it. It's sitting in our office right now. Oh, what's her name? I can't think of it. But she was a neuroscientist. It's going to come to me. I said it 1,000 times. But she's a neuroscientist, and she had a stroke. And she was able to feel as a portion of that stroke where she felt like she just kind of like dissolved into the world and lost like the borders of herself. And as a consequence of that, it gives us an insight into understanding, like, as these areas of our brain work and perceive our body, they allow us to be able to define the borders of this body versus the world at large. So we can find that when we affect those areas, particularly in the parietal lobe, that we see these kind of changes in our sense of self. And dissociation can be a part of that, whether it's from the injury that is more chronic duration or something that happens acutely, or something that may come and go due to ischemic changes. And that's probably what a lot of people feel, is where it's kind of coming and going based on how much we're stressing or taxing that system for a person. Okay, so we are trying to do this interestingly here, because I can see, I'm trying to do it where I can see the comments, but I can also get some questions at the same time, so I'm not missing all of like the responses to them, but it doesn't it's a little clunky feeling at first, so let me do my best here. Okay, so next question we have on the list, let's see, big shout out to Dr. Marsico for helping me with this. Is there anything anyone can do at home to calm or balance their vestibular system? So I would say two parts to this question. Number one, that's a tough one, because your vestibular system is multi-part. You've got a peripheral system, you got a central system. The central system is also gonna integrate inputs from your eyes and your proprioceptors, right? So it becomes this diffuse network. Number two, when we say calm, I think I understand what that means, the feeling that we have the movement. But also, we have kind of two different directions that the vestibular system can run. Sometimes we can have it malfunction to where it is hyperactive. We are feeling gravity, we are feeling movement that is not there, and that's problematic. And in that sense, you probably would want to feel like you'd want it to calm down. In those instances, that may be because something is actually overfiring, or it may be because the thing that should be countermanding or opposing it is not firing enough, so the normal signal feels like too much. The second piece of that is like things you can do to balance it at home would be specific to where that problem is. If it's in the periphery, you're going to solve that a certain way by being able to stimulate the peripheral receptor. If it's in the central system, same thing. This is often the basis of vestibular rehab, where we kind of generalize it and they say, like, do these things called Cawthorne-Cooksey exercises, which is, shaking your head back and forth and up and down and, watching your thumb go opposite. But normally when we watch people do these, it's way beyond the scale of what they should do with their particular problem. And what we actually want to do is be more specific. So if we're looking for the general kind of like try to hammer it ways, what you would typically go through with vestibular rehab is going to be suitable. And what they're doing is a series of vestibular rehab drills that are considered, they come from Cawthorne-Cooksey. It's an older model where they would kind of walk through this progression and just have everybody do that. It hopes that it would kind of recalibrate the vestibular system. Works for some people, doesn't work for others. Okay. Holy moly, I got a good friend here, Benjamin. Hi from Cayman. I'm jealous. Good to see you, man. Glad you're there. Hopefully you're having some fun. I know you're staying warm. Good to see you. That's awesome. I'm glad you're here. Wildfire coming to the rescue. Jill Bolte Taylor. That's who I was looking for. I don't know why I couldn't think of it. That must tell you about we've had a busy week. Melissa is here. What do we got here? We got some questions. Just checking in. Feedback. Sorry, hurry. Okay, I'm going to jump in with questions from next question. What do we got here? I'm looking at these on my phone because I was ill prepared and I couldn't figure out how to get the Google Doc up on my computer fast enough. So, what do we got? Nicholas, how you doing, man? Sick with the flu, that's how he's doing. If you don't do any exercise for a week, does it ruin all the progress you've made? No. If you're sick, man. It's okay. Just heal up and get better. And then just as soon as you're able to feel like you can get back on it, then just start where you're left off. You may have to scale back a little bit and kind of build back up. Just like if you were running or working out, it may take a couple workouts to get back going, but often running. So that would be my advice. Heal up. Flu's okay. No need to get worried about it. We just get back on the train when it's time. Okay. Good. I'm glad you're here. We're rooting for you like crazy. So good to see you. All right, Benjamin. Maybe seeing you soon. We'll see. I hope so. I think that might happen, and I'm looking forward to that. So hopefully I'll see you there. Melissa. Oh. We're gonna get. Are you guys gonna start talking in Spanish, and I'm not gonna know what's going on? But that's kind of fun. Dímelo. Okay, next question. Thank you, Nicholas, for writing in. Hope you feel better soon, man. Matheson. How can you tell if you have too long of a styloid and need surgery versus if they have internal jugular vein compression that can be treated by treating the neck? Great question. If neck treatments help temporarily, how can you determine if it's helping with the vestibular system versus helping that vein compression? So, great question, and it's timely, right? One of you knows why that's timely. So let's talk about what it is. So what is the styloid process? So the styloid process is kind of right back here, comes off your mastoid. The mastoid is this bone you got on the back of your head that connects to your neck. And for some people, we get this, everybody has like a little fang, a little styloid process that sticks down, and it becomes an area where you actually have some connection with some muscles that come in and around your throat, help you with speech and some different activity with moving the hyoid bone around. Okay, so what can happen though is for some people it can become ossified, and when it becomes ossified it gets a little bit longer. But the problem when it becomes ossified is that it can start to cause some compression on some other stuff, especially when you move your head. Now, this is the age-old question, and do you just get the scissors and clip it off, or do you think about how the movement may be off? I can see as my movement's off that my camera's off here. Okay. There we go. So, so if that movement is off, we may find, so this is like the classic bow hunter syndrome. So anybody who's not familiar with that, bow hunter syndrome is this idea, obviously when you shoot a bow, you turn your head, and as you turn your head, does that styloid compress either the vestibular, or the vertebral artery that comes into the back of the posterior circulation, or do we start to get changes where we get an effect on the carotid that comes to the front, and then we occlude them? Or number three is, do we get some compression of the internal jugular vein and it backs up into the head, right? And we talk about this all the time. And then the question is to what degree does having that styloid process in there make a difference? Now, for some people, it's going to be a surgical event, and you'll know that because nothing changes it. The tougher one is we will find all the time where we will be able to see where people will have, changes in blood supply when they turn their head. We can do things that affect the way that they move, so it makes the movement more clean, less blocked, and we see that they no longer have those cuts, but the styloid is still going to be there and longer. And then that kind of becomes the chicken or the egg question: is this something that is a function of the actual, like the styloid is just too dang long, and no matter what it's going to be problematic, or is it a function of the way I move and rotate and control the movements of my head, where maybe that styloid is actually not too long, but it's the problem with the way that we have the position of our body that allows it to compress. So the corollary to that would be, some people might say, like, this is the same thing we think about with CCI, where it's like, well, when I flex my head it can go too far, and then that can cause an impingement on the jugular vein or the carotid or the vagus nerve or something like that. But then the secondary question would be, well, also, what if we can just improve the way that you control the kinematics of your neck so that you're not going into those distributions and not causing that type of compression? You're staying in the road, so to speak. You're not driving off into the ditch. And if you're not driving off into the ditch, then you don't have to worry about it. So there's two ways to think about that. Some of that's personal in terms of, number one, what your tolerance is for surgery, right? Some people, no big deal. They don't mind. Surgery every year is good for them. And they will be more likely to go through that procedure. It may help, it may not, but then they'll solve the problem as it comes along. The other way to think about it may be related to, like, maybe you don't want surgery, you don't usually respond well to surgery, or you want to try something conservative first and see how that goes. And I tend to lean toward that in some ways because it's just like how I'm wired, but also it's easier, like if the conservative thing doesn't work, you're not out anything. You didn't change any structure, you didn't change or break anything. And then you can always still do the surgery, but you can't do it the other way. So you can't like undo the surgery and take it back and put everything back in and say, just kidding. So I tend to kind of operate in that way where it's like, if we can do it conservatively first, awesome. If that's just not working and surgery is the way out, then we work on those things as well. So so that's kind of the thought process that you can use. But it depends on how long the styloid is. I see actually a lot of elongated styloids that are like not that long, and they actually respond really well to conservative care. And then we just keep an eye on it, and if we find that like they can keep trucking and use kind of their own body or their own kind of natural movement to be able to keep that at bay, then we just keep leaning them into that, and that can be a really useful tool. And I've also seen styloidectomies that don't work because it doesn't change the movement parameter, so they pop the styloid out, may cause a different problem. We've seen that. But then also we just see other things with motion of the neck that were actually the problem. So it can go both ways. Cool. Wee says, I tend to wake up during surgery. That's not great. You're one of those people that's got too much electricity in your brain. You can't shut you down. I love it. Okay. Looks like no more questions on that one. Fatima says, hello. Hello. Denise says, this is my subject. Yeah, it matters. I'm not opposed to people seeking out those surgical components. I guess my bias would just be the conservative routes can be really effective, and you still always hold the option open to do the surgical ones. So I tend to lean that way first, and that typically tends to be kind of the do no harm way to approach it. Let's see. All right, Switz asks, can a nickel allergy or sensitivity affect POTS flares or gut issues? Any kind of allergy that is the net problem. So we always talk about POTS becomes POTS when it's not something else. So if we're having an allergic reaction to something or a sensitivity to something, then that may be the underlying issue. And then you just want to measure that. It's hard to measure, but you could also look at exposures to it to see if that yields a result. Part of the other problem is just knowing you have a nickel allergy and being aware of potential exposures makes you more likely to have the expectancy that it'll cause a problem too, so then you get a whole ball of wax around that as well. The second question is, can hyperbaric be helpful? I think hyperbaric is a great tool because it allows you to be able to bind more oxygen to to hemoglobin to allow you to carry it deeper into the cell, which is pretty cool. It helps you to maintain the charge so you can open the capillaries. So overall, it helps to improve the perfusion of blood deeper into the tissues, especially if they're already having a harder time perfusing them, which can be a net positive, which can be really great. Now, for most people, it'll take multiple dives, or you have to do a program to understand if it's going to work for you. But if you're willing to do that, it can be a really great tool. Now, with that said, it's also useful to understand what is the problem you're trying to solve. So if getting perfusion deep into the tissue is the problem, hyperbaric is the way to go. You may find that it is a good ancillary tool, which means it supports the other things that you're doing. So you may do some form of rehab where it's beneficial to also then try to flush that blood through so that we can heal faster, right? So it's usually looked at as a way to support other types of therapies in terms of recovery. And I think that's a strong way to look at hyperbaric, is like a recovery amplifier, a way to be able to get your system to be able to maximize the amount of oxygen that moves through it so you can maximize that tissue recovery response. So, hope that helps. Okay. All right. Denise asks, I feel like one of the people on the radio shows where you call in, I guess that's kind of what we're doing, isn't it? So Denise asks, will you describe the most effective way to determine if someone has cerebral hypoperfusion? Is it important to resolve this before treating head injury, or is it more important when compression is above the heart? Let me ask again. Is this Denise or Dennis? Okay, let me try that again. Will you describe the most effective way to determine if someone has cerebral hypoperfusion? Is it important to resolve this before treating a head injury, or is it more important when compression is above the heart? I'm not sure what that last part means, but hypoperfusion is just a way of saying, let's define it first. So it's where we're seeing evidence that cerebral blood flow velocity is typically how we look at it, and that's using transcranial Doppler ultrasound. You might use other tools to describe it. SPECT imaging has been used in the past as a way to do it. One thing that's harder about using imaging techniques is usually you have to be laying down to do them. And for a lot of people, it's not the laying down part that's hard, it's the standing up part that's hard. So if that's true, the Doppler becomes really useful. We look at that cerebral blood flow velocity as a way to understand the difference or the delta between what happens when we're laying down and we're upright, and then we can see where that perfusion is changing into the system. So the question of, is hypoperfusion, like how do you test for it? As far as being able to test it in a dynamic way, where we can compare the difference between laying down and standing up, we can compare the difference between different types of head movements, different types of arm position, and we can be able to see what changes it and look at it as a dynamic measurement. So that is my kind of like favorite way to do it. It's a low cost, portable, accessible way to do that. Ginny says the last part of that question was my mistyping. Sorry, Denise. Is it important to address that before addressing head injury? So that's a good question, because it's hard to separate them. If you think about trying to heal a head injury, like we just talked about with the stroke paper, right? They're saying that in order to heal, we have to be able to do two things. We have to be able to stimulate the neuron, and then we also have to be able to get fuel to the neuron, which is going to be oxygen and glucose largely. So if we're having hypoperfusion, not getting enough blood flow in, it's really hard to get enough oxygen and glucose to that cell to be able to help it get stronger when we stimulate it. Otherwise, we stimulate it and it doesn't have any way to fuel itself, and then it becomes problematic. So I wouldn't separate them. I would say that treating the head injury while also understanding what the perfusion is like a superpower, because it lets you say, I want to be able to stimulate that brain to be able to heal it at the rate that matches the glucose and oxygen delivery to it. And if I can do that, then it allows me to build strength and momentum within that system so that we can keep it going up and up and up. So I would look at them as a team and say, if I can understand them both together and work at them together, then that allows me to be able to be more specific in terms of the stimulus that you're using. And then also more specific in terms of the dose. So it allows you to pick the right thing to target and then the right amount of effort to put into that, or the right amount of stimulus to use. So that's a great question. Well done. Even with a typo, we nailed it. So great job. Professor MJ, ooh, I like that. Let me get a drink of water real quick. Okay. Oh, Robin's here. Late night over there across the seas. Glad you're here though. Okay. We got Professor MJ. What are your thoughts on an adjustable bed for POTS? I got my son one. Dizziness and headaches have improved. Sleeping with the head elevated. Well, number one, I'm super happy that he's feeling a little bit better. So I love that. And then about it being an adjustable bed. So one of the early things that was done for people that have any sort of orthostatic intolerance was starting to raise the head of the bed. And this was done because by raising the head of the bed, it puts a little extra pressure on the kidneys. And when it does that, it causes us to hold on to a little bit more volume than we otherwise would. And that little bit of extra volume may be useful in creating more vascular or venous return to the heart. So we return more blood flow to the heart. And that allows us to circulate more blood with less beats of the heart, which can be great. Now, secondary to that, if you're having dizziness and headaches, I would wonder what the underlying cause is of the tachycardia, and then maybe think about what is going on in vestibular and cervicogenic integrations, where maybe we're looking at different positioning, or we're not exacerbating some of the vestibular components laying down, or we're not irritating the neck by laying down all the way, or we're being more supportive. So there might be another layer in there that might be useful to understand and maybe step back and think about. Not just the volume component, but what else is happening within the system, and can you leverage that more? Can you lean into it even more to get more result out of it? So that would be my next thing, is saying like, okay, so I'm seeing a little bit of change. What is changing? And then how can I lean into that and use that as a way to understand where to go from here? Cool. So yeah, great. I hope your son does really well. Looking forward to hearing great news from you and him. Okay. Is there a benefit to using Normatec for blood flow for someone who has POTS? Good question. So what is a Normatec? So Normatecs, you've probably seen them. They're these big air boots that you can wear that go all the way up, and I'm pointing like you can see my legs. I know you can't. I see that. But they come up to your waist, and you zip them on, and they've got these little pumps, and they pump air in, and it kind of like, they've got chambers, so it starts with your feet, and then it goes to your calves, then up by your knees, then up to your thighs, and it will kind of use that like a little squisher, and it will push that, it'll compress the legs and move that fluid up. So it can be really good for lymphedema, being able to kind of push some of that fluid in and around, which can be nice. We have it, we use it. We don't use it with everyone, but we'll use it in cases where we get high levels of lymphedema, where there's a lot of swelling in the legs. And when there's a lot of swelling, that can help push some of that fluid back up. One thing we'll notice, so just like 2 weeks ago, so we had this case where it was a peripheral neuropathy, and we don't have good feeling in the legs, and we're trying to stimulate those nerves so that we can turn them back on and get them running again. And with that though, it's hard to stimulate a nerve while you're also compressing it. So what we did was use those Normatecs to be able to compress some of that fluid out. And you'll know this, like if you push into the ankle and then you take your thumb away and there's still an indent in there, it's called pitting edema. Like you can see the pit. It leaves a little indent, a little pit in there. And that tells you that there's fluid accumulating in the leg. So a lot of people talk about pooling, and they'll say, my feet are purple and they're colored and they're splotchy. But when you go in there and you press and you look for that edema, then we're not really seeing the edema. That's a little different thing, right? But if we're seeing that fluid collection where it's, causing swelling in the legs, then we can use that as a way to push it out. You may find that you just like the way it feels. Also, people notice that they like compression socks, compression pants, compression abdominal belt, whatever you like. We talked about last week that sometimes that compression can just be a way to like give your body a hug, to give it a squeeze so you feel it better. And just that the component of feeling it better can allow you to be able to create a map that's stronger and be able to improve the circulation, right? So sometimes we think about like we're squishing the blood back up, but that might not actually always be the case. It may be that we're just giving ourselves more neurological signal, and then we can close the loop. So those are a couple ways to think about those pants. And then also they can just be relieving because they're like a little massage on the legs. So I don't see a lot of downside to using them. I wouldn't buy them thinking like this is going to solve everything. That's probably not what it is, but it can be used as a nice tool to keep fluid moving in the legs and to stimulate the legs, especially if you're not walking around a lot, and to be able to just get some of that movement stimulus back in. Good question. Okay, let's see where we're at. Okay. Okay, so Linda is wondering, I need to work with local docs, where do I start? Diagnosed with dysautonomia, EDS, histamine, not sure what that means, vestibular migraines, oscillating vision, small fiber neuropathy, no real cause or treatment plan. Well, okay, so I'm gonna give you this in a way that is not meant to be harsh, but it's gonna be like objective. So when we look at it, we've got like a dysautonomia diagnosis. Okay, cool. We've got this component of just a very simple structural component with the EDS. Histamine, I'm assuming that's some sort of like mast cell type thing. It'd be nice to know if we've measured that or if we're assuming that. I've noticed lately that sometimes that just gets like EDS and MCAS like get thrown into the mix without testing for it. They just say, well, you probably have these things too. So it's worth knowing if we're testing for them or not. Vestibular migraines, oscillating vision. So vestibular migraines are typically like the come and go versions of dizziness that come in spells, like a migraine would come in a spell. They tend to be relieved with sleep, and they're not described, it's dizziness not described by BPPV in the periphery, nor swelling inflammation within the vestibular or the vestibulocochlear nerves or central origin. So sometimes we can miss a thing or two with a vestibular migraine. It's not a true migraine, but we can't know without looking. The oscillation in the vision, I'm not sure if that's like describing square wave oscillations or if it's oscillopsia, where I perceive, like when I move, the world is bouncing. That would be oscillopsia. And then small fiber neuropathy is separate. So that's obviously going to be in the peripheral nerves in the legs or the arms or the trunk or whatever it is. Okay, so you got a lot of different smattering of things. If you're looking for a local person, you have to recognize that we have these correlated problems. These things all tend to go together, but they're in different systems. So when you look for someone local, you have to look for someone that is going to understand how these things are all correlated. You also have to determine what type of treatment protocol you're interested in. Are you interested in something where we're looking for a medication to resolve some of the symptoms, to get a little relief, feel a little bit better? Are we looking to solve the underlying? What are we looking for? And then you're going to back out to like what, in my geography, how far am I willing to go? What is the talent pool like in that area? And what is the likelihood that that talent pool is going to be able to solve my problem? Now, with doctors, it's hard because sometimes we forget. It's the same as anything else where you should interview them. Like, right, the same way you might say, like, I want a good attorney or I want a good accountant. Like, and you interview them and you see if it's a good fit. Sometimes we just go to the one we get and they're not a good fit and we get stuck with them. So it's important to remember that you're kind of interviewing your doctor too. And you're trying to see if you feel like, based on the things that you understand, can they add to that? Can they do things for you that'll help you to be able to move farther down the road? So I'm not giving you a specific answer of here's where you go look. There's some resources with the ACNB, although I think their website's down. I think it got hacked. I don't know if that's fixed yet. But unfortunately, I don't have a good answer because it's going to be like you're going to have to hunt around in your area and do a little bit of research. Without knowing your area, it's hard to know how exactly to help you with that. As you know, it's 8:45, which means we get to take a little intermission, and I get to say goodnight to my kiddos. Come on over. Hi, babies. Oh,
American! American!
You got American flag in the face? You okay?
Daddy.
You got another loose tooth?
Daddy!
You're going to run out of things. We're going to get you some
American!
pictures. All right. Did you have fun? What did they have tonight? Was it a magician? Was it a...
Magician.
Magician tonight?
No, he like juggled.
Juggled.
He didn't do magic.
No magic, just juggling?
And he balanced chairs on his nose.
That's pretty cool. How many did he get?
He got like
10.
10 chairs?
Yeah.
That was pretty good. Nicely done. We'll practice that in the
And
dark.
when at the end, he balanced $1 when we were leaving.
Did you get it?
Daddy, and he juggled a bowling ball, a knife, and a phone.
At the same time? That's a lot of different weights. That's pretty good.
Daddy,
Was he the guy that-
and he was
the guy that like walks on glass.
Yeah, he's good.
Yeah, I like
Yeah,
him.
I like him.
Daddy, and he juggled an apple while eating it.
How many bites did he get?
He ate a whole apple.
Whole apple?
And then he ate the last bit.
Wonderful.
He threw it up in there.
Want to say bye to everybody?
Bye, bye.
Okay. Even though it's going to be like further out. But we got camps and everything tomorrow. Cool. I see a van door open. Make sure you close it.
Okay. Daddy, we saw a hot air balloon.
A hot air balloon?
No, like what? A hot air balloon. Oh yeah, a hot air balloon.
That's pretty cool. Did you get a picture?
No, but I saw it. American! Ah,
Be careful with that thing. You can take everybody out.
American!
Okay, will you close the door for me, please? Love you. All right. Thank you, everybody. Thank you. Okay. I think we left off on like, how do you find someone near you? Which that is a question I am super sensitive to because, I mean, as you guys know, I mean, there are people on here from all over the world. There are people in the clinic from all over the world. It is not easy to find somebody that feels like they got a grip on these things. So I'm sensitive to that. I know that's tough to find. Like the candid part of me wants to say like, come to Michigan, but I know that is not for everyone, so I don't want to say that, and I don't want anybody to feel bad. And then the second way is like, how do we find somebody near you? But that's the honest answer is like, we actually have to think about it in terms, we gotta like start with what the end result is that we want, and then work our way back. Say like, well, I'm looking for someone that's maybe not gonna try to mask it with medicine, which means you need someone that's focused on not medicine. Or you might need to say like, I need them to be able to understand the autonomic part, but then I want them to be able to weigh in on how all these things like work together. So finding people like that is really useful. I have some colleagues that are learning that and that are sharp and really great people. Sometimes there's cardiologists that are wonderful, neurologists that are wonderful. I just don't know. We don't have like a WhatsApp chat to talk about that. So I apologize for that. Okay. Oh, here we go. Okay, 1 second. Okay, so I'm going to go through a few of these. Dr. Ginny wants me to we're going to talk about, we had considered talking about PNES. We've got that in the clinic this week and last week. And there's a question about that, so we're going to probably talk about that in a minute. But Peace Love Mungbean says, why as some recover they find their tipping point where POTS-like symptoms kicks in, delays further into the upright exertion? Is it likely muscle fatigue or something else? Further into the upright exertion. Interesting. I'm not sure I know how to answer that because I don't know how I fully get the question, but as an anecdote, and maybe I'll find my way there. So one of the ways we used to work through this, and we still do to a degree, is when we were working through cases of POTS, we would progressively move people from where they could maintain their blood flow, look at where it breaks. So we put them on tilt tables, see where that starts to break, and then take them just below that and actually do work at that range, and then try to move them up bit by bit. We've gotten a little more nuanced in that since then, but I think that's a useful idea that people can even start to maybe entertain at home, is like figure out where's my breaking point in terms of even just like at what level of elevation, and then be able to start there and say, what can I do here? So for example, we exercise people laying down, and then we modify that tilt and then work toward getting them up to recumbent and then eventually to standing as a mechanism for being able to just like gradually move the brain and to be able to understanding where it's at. And I don't know if that's really what this question's about, but it's one thing that can be really helpful in pairing position to stimulus. So we know what stimulus we want to apply. We're going to use the position that they are still able to perfuse their brain, so that we're able to maximally start to move both up together, and that can be one way to think about it. Okay. Okay. And I don't know if I answered the direct question or not. I apologize if not. Okay. Okay. Let me see here. So Linda says she's in Atlanta. Cardiologist, neurologist, left Emory. P.S. Beautiful family. Thank you for that. I'm very lucky. I like that I get to spend time with them a little bit at night here. It's fun for me. Yeah, Atlanta. I have some colleagues in Atlanta that are chiropractic neurologists. You can definitely look up. I love living in Atlanta. I'm curious where you are, but yeah, there are some people you can reach out. We can connect you with a few people that we know down there and see if they could be useful for you. I'm going to answer Rob's question real quick, Dr. Ginny, because it's 4:30. I think he said. So just while I see him here, he said, "I live in a super sunny part of the world. I'm jealous, but I also love it for you. With sun exposure being beneficial, how much time in the sun would one need to reap the benefits if you're dark-skinned? I read that darker folks absorb less." So actually, you're gonna, yeah. So it's not a perfect analogy, but you can kind of think of like the level of melanin in your skin, or like the darkness of your skin is dynamic, and it changes relative to the amount of UV radiation that you're acquiring. So what's really cool, every cell's got a nucleus that has its DNA in it, and we know that radiation can affect the DNA, cause mutations which aren't good, but your body already knows this, which is pretty awesome. And what it will do is when the UV index starts to go up, we're getting more UV exposure, then we will see the skin respond by putting more melanin in the outer layer of the skin. And you can think about that as like, obviously the melanin's pigmented, so the darker the pigment, the more it's going to absorb. Just the same way like when you look at your pupil, you want the light to be absorbed into that little black part there, because that's where it's going to go be processed. But then you think about this white part on the outside, that's not really processing the light so much, and that's white, so it's going to be a little bit more reflective. So we will use that melanin as a way to be able to almost make ourselves little solar panels, so we can absorb the sunlight, put it to work. But then also it allows us to be able, as it's absorbing it at this layer, let's say, so the sun's coming in, it's absorbing it here, but it's also creating shade for that nuclear part of the cell on the inside that doesn't necessarily need that penetration of the sun, especially the UV radiation. Now, where it may account for more of that red light moving through the system, which is pretty cool how that works. So your question is, how much do you need? And then if you're darker skin. So generally speaking, if you've got darker skin, you actually need to have more input of the sun to be able to get to the same dose, because it's being absorbed. Now, there are some simple rule of thumbs, but it's kind of the heuristics of that are like the darker your skin, the more the better, and you kind of build up a callus to it. There are people that talk about this at large, and kind of the more of a solar callus you're able to develop, the more you can be in the sun and to be able to tolerate that. Now the minimum dose would be, thinking about it in 3 waves, you think about like sunlight without UV and sunlight with UV, and we kind of want to maximize the sunlight without UV exposure early in the day because it primes the skin to be able to tolerate the UV in the middle of the day. We need a smaller dose of that, so most people can get away with 20-ish minutes as a minimum in the UV exposure during the summertime, and then once the sun starts to go down, the UV exposure is down, then being able to maximize the kind of the more red light exposure on the back end of the day. Most of you have seen like red lights are wildly popular. We use them in the clinic, but they're meant to mimic that time frame from our red sun where we're outside of the UV exposure and we're trying to stimulate that red light within the system. The sun's red light is better. It's denser, it's more full spectrum, it's kind of more what we're built to tolerate. And then adding in the dose of UV in the midday helps with circadian rhythms, but it also helps to give us that exposure of the full spectrum of the sun. So I think it's a really good question, actually. I think we can talk a lot about more. There's some really good resources online, people that know a lot more about it than I do. But the way I usually recommend it is as much as you can while it's red light, work up to 20-30 minutes or more depending on your tolerance as you go during the peak daylight hours, and then once that sun starts to go down, kind of absorbing that red light again. The good news is when the UV is not there, you're not going to get burned, so you can tolerate it more even if you're of a very pale skin, which a lot of POTS folks are because they don't get to spend a lot of time outside, they don't do well in the heat, and that can be a good way to start to get some gentle exposure as you're moving along. So great question, thanks for asking that, Rob. Good morning. Hopefully the sun's coming up soon. All right, where are we at? Skipping around a little bit here. Okay. Trying to get located here. Okay. So the one we're going to talk about with PNS. So we looked at the relationship between psychogenic non-epileptiform seizures and POTS, and we talked about the fact that there is an overlap in the Venn diagram of those things last week. The question was, so the quote from the question was, PNS is a protective response. POTS doesn't cause seizures, but rather convulsive syncope from cerebral hypoperfusion. Using the term PNES creates confusion as if it's a distinct condition with different underlying mechanisms, though it can often occur with POTS. PNES is caused by dysfunction in the brain wiring, while hypoperfusion can trigger a dissociative episode in someone with both PNS and POTS. Is different than convulsive syncope seen in POTS. So I understand the syntax that you're trying to work with here, or the semantic component. And also, it's helpful to understand with PNES as the psychogenic component gets bled into other components of functional neurological disorders, right? So there's an overlap in the epistemology of the wording. That's really helpful. So the point you're that Jules is trying to make, Julia or Jewel, I'm not sure, is kind of differentiating between convulsive syncope versus PNES. Now, where the overlap happens is you have to look at the system as it is as a whole. Like, we don't get to make the decision about like the difference between wiring and plumbing. They are together. So all the wiring is connected to plumbing through the glial cells in the end feet. So to talk about it in terms of wiring is to say there's a dysfunction in the actual makeup of the cells. That's probably not true. We see connection changes, or we see epigenetic changes, we see functional changes that can occur that are pattern changes, or the way that a system may choose in context. So these are motor disorders. When we think about movement disorders, we think about them in terms of the way we have these functional connectivities through the system. And they start with afferentation that comes in. So we need afferents that come in from the external system that are processed through the cerebellum and the dopaminergic centers in the midbrain, and they get projected up into the thalamic relay centers, and then that picture helps us to be able to filter that down and then create a picture of a person, your internal representation. And then internal representation gets pushed forward into motor programming and the goal-directed behavior. And then it gets dumped back down into the thalamus. Again, to go back through that filtering mechanism, we're filtering out motor programs, and then we're able to direct those. So one of the things that this calls into question is saying, like, we're asking to differentiate between something that is psychological and something that is neurological, by saying it's protective, meaning like there is a thing that is happening where we're seeing, some people refer to it as a faint, but other people will refer to it as seizure. So if it's a seizure, then we're looking, the main feature of psychogenic non-epileptic seizures is that when you look at the brain and we look at the EEG, if we're having an epileptic seizure or a seizure where we're seeing a spreading depression in the brain, it changes the waveform of the electrical signal that goes through. Whereas in PNES, we don't get that same change in the electrical waveform, although we're getting a motor response that is we could call it atypical, or we could call it like non-productive in a way. It's a tough way to look at it, but that's probably a way to think about it. So the question is that something that someone their body is doing as a protective mechanism? Maybe so. But also we can see that in that trigger where we're dealing with the hypoperfusion, it's hard to talk about something in terms of just being a trigger, because if the hypoperfusion is there, then we know that there's an error in the functional connectivity of neurovascular coupling, meaning if the system worked correctly, then as it perfused, there would not be hypoperfusion. So the fact that there is hypoperfusion tells you that there's an error in that system, especially if it's a non-obstructive type of hypoperfusion. So it already tells you that neurovascular coupling is impaired, and you might say that's a wiring problem, but you would also say that that is a problem with the functional connectivity in that area between the neuron and the glial activity, removing the glial end foot and causing this happen. You'll see these happen in people that have mental tasking type of events that will cause it, and you can see an overlay where someone might have, like, they're thinking about something, or just the mental tasking itself, you see them bog down and then they'll go into that type of an event. Or you may see them related to an emotive event. Now, a lot of times with the term psychogenic, people will try to over-index it toward looking at an emotive event or an emotion or like an emotional protection as being the culprit. But we also see in a lot of cases where that's not the case. It's not the emotionality that changes. You can change it with eye movements, you can do it with positions, you can do it with cognitive tasking in ways that aren't necessarily of yield in an emotional context. And that's really helpful because it helps you understand in the basal ganglia the different loops that are being used in that filtering mechanism of the motor control system that allow you to be able to differentiate oculomotor patterns versus somatic versus cortical frontal versus limbic, these loops that go through the basal ganglia, and understanding what the different catalysts can be helpful. So there is a correlate between POTS and hypoperfusion and PNES because we see the same correlate. POTS is just the ability of your brain to be able to ask your heart to work harder to try to compensate to a degree of hypoperfusion so that we do not have irritation or damage within the brain. So POTS is purely the mechanism that goes along with your brain trying to preserve itself. So to say that you can't have POTS and PNES overlapping disregards the fact that we have autonomic activity that's reflexive that will try to protect the perfusion of the brain, regardless of if we're going to evoke a syncopal event, pre-syncopal event, or a non-epileptiform seizure, or a classical seizure. So those things all kind of have a predominance of understanding how does the vascular system overlay within that, not separating it out, but understanding that the ability of a neuron to be able to attract or to be able to signal to the glial end foot to then dilate the local vasculature, dilate down into the PL arteries to pull that blood supply in, we can see if there is in fact an error in that vascular coupling as a mechanism to help people through those types of events. So I hope that's helpful and useful in being able to understand how those things are related. Cool. All right. Dr. Ginny wants to know if she should sleep on a wedge pillow to assist in venous drainage for vascular TOS. A wedge pillow can be useful. And same thing we were talking about earlier. Professor MJ was talking about his son and being able to be on that angle. So same concept. We know the angle helps. We don't know why for sure, but we know that we like it. And this is a case where we're saying if we've got a vascular thoracic outlet where we're perhaps causing a difficulty in the drainage of venous blood draining out of the head and back into the thoracic cavity, sometimes positioning of your head while you're sleeping, everybody's got like a favorite awesome sleeping position. But sometimes that can get impaired, and you'll notice that because you'll wake up feeling not good, or you'll be kind of tossing and turning around all night, or you might feel a little bit dizzy in the morning and stuff like that. But for some people, if that thoracic outlet is a component, being able to sleep in a way where you're opening this up, this space between the clavicle and the first rib, allowing that shoulder to rotate back a little bit without compressing, and allowing your neck to have open space to let that drain, can actually be really useful in allowing that system to drain overnight. And we may find that just your favorite way of sleeping from when you were a kid isn't compatible with whatever injury or lifestyle event happened that changed the output, and then we start to compress it, and it can be problematic. And you see a lot of this, especially with people with head injuries, where they're used to sleeping on their stomach. You know who you are. So if you're sleeping on your stomach, but you're used to like kind of doing one of these numbers, you might not be able to hear me, where you're cocked to the side, but then you also had a head injury where you took one of those, you might find that all of a sudden, as part of that, when you sleep like this, you wake up and like your eyes are blurry, or you're like trying to crack your neck, or you're moving around a lot, or I'm feeling dizzy. Might be indicators that even though that is like your favorite way to sleep, it might not be the most optimal way to sleep. And like Dr. Jeannie is talking about, using a wedge can be helpful for some people because it can kind of force you, lets gravity kind of do some of the work for you. The one thing I would note is some people have a hard time when they start to tuck their chin back like that. It can be obstructive. So being able to still have your head in a neutral position but on a wedge, if you can tolerate that and you can sleep, can be a good trick. Cool. Beats and Pieces Studio, I like that name. Should there be concerns with treating ADHD with medication when you have POTS? Will this exacerbate the symptoms? That's a good question. So, worth pointing out, those of you new to the channel, can't give medical advice, not a prescribing medical doctor. Love that, so I prefer it that way. But the question is do we see problems ever with using ADHD medications when you have POTS? Some people will use some people will be prescribed ADHD medications as a way to combat the low energy. So it kind of will be like in the sequela, or in the progression of things that happen. Eventually they're just like, well, we've given you the beta blocker, you've had the Midodrine, the volume expander of Fludro, we've given you everything, but you're still tired. Maybe we give you a stimulant as well. And then if you get real good, you get the stimulant and then also a sleeping aid as well, because the stimulant makes it hard to sleep. So that stimulant portion is kind of like the ADHD portion, where people can use it as a way just to give them a pop, a stimulus, a boost of energy, taking speed basically. So if we're doing that, then think about some of the symptoms that people experience with POTS. A lot of them can be relative to this secondary effect of having energy mobilization. So in other words, if I'm having a hard time feeding my brain, I'm not getting enough oxygen in there, I'm working really hard, my heart's beating like crazy, that's a secondary effect. The secondary effect is to try to produce more energy within the system. That's why when you measure norepinephrine, it's going up, because we're trying to drive that sympathetic signal more. We might see that volumes change. We may see that heart rate's going up, sweating's going up. The distal perfusion of the vessels is changing because we're trying to get more blood into the central system. So all these things are secondary responses, changes in CO2 levels, but they're all to try to preserve and compensate energy. So we're trying to pull blood into the middle and then be able to pump as much energy as we can to be able to deal with this problem we're having. A lot of people with ADHD will find that they do get a jump in activity or clarity that comes with that, because we're affecting we're affecting the cholinergic system. But on the back end of it, it can also be harder to recover, and then we're also kind of giving that system some extra. We're pressing it in a way that can make it harder to recover. So it is a common thing where people will use the stimulants. I generally tend not to get super excited about it, because it usually means that after we solve the main problem, we're going to have to help them deal with solving the next one, which means, working with their prescribing doctor to help them titer off of those medications as a way to kind of balance that back out and get the neurochemistry back on track again. So it's not my favorite thing. If you're worried about it, I would talk to your prescribing doctor and just tell them what your concerns are and get them on your side. Don't be antagonistic. Don't go in like you know it all, because they'll just turn off. And if they turn off, then they're not useful, and then you got to start over again. But by being able to like find some common ground and saying like, here's what I'm worried about, what do you think? It gives them the ability to then be able to like help you, or like you help them come up with your solution, which can be really helpful. So I understand why that's hard. I also understand that like if you're already taking that medication, coming off it can seem like a bear, but it can also, in the short term, that energy is kind of like the only thing that you got, so it's hard to give it up. So weighing that out is kind of tough, but can it have an effect in POTS cases? Yeah, it has an effect in everybody because it's a neurotransmitter. It messes with your neurotransmitters, so it's just a thing to consider in your calculus, is in terms of like how you want to start to address that, what order you want to work in. A lot of times we'll start trying to address the reflexive things first. We leave those medications alone, and then if we get to a point where people are feeling strong and they're like, okay, I'm doing really well, now let's see if we can start to pull those medications off. Sometimes that is the approach we'll often use. So you don't have to feel like a panic about trying to get off them necessarily right away, unless you're having some other problems. Cool. Hope that helps me. Robin, follow up. Did I understand that correctly that red light from the sun is only for specific times of the day? Can you clarify what times? Okay, let me back that up. So the sun's always got predominance of red. More than 40% of it's like if you think about when you look at a white light like these here, they've got a full spectrum of light, but it's not equal. It's not equally distributed through them all. The biggest portion of the spectrum is red. It's like 40%, a little bit more than 40%. And so in the morning times, you're getting a spectrum, but you'll notice like when the sun comes up, it's got that orangey hue to it. Because of the orientation of like how high the sun is in the sky, we're getting predominantly a red. We're getting all the colors, not any UV necessarily yet, but all the other colors. But that's predominant red. As it moves higher and higher, we start to see more of the UV exposure come in. It's still going to be red, but it's going to be matched with a lot more blue and then the UV light. And then as it sinks down toward the end of the day, that UV light's going to wane, and then we're going to be left with the red light again. So, but if you're trying to get exposure to sunlight, the factor that's going to limit a lot of people is the actuality of getting burnt, or the fear of getting burnt, and the discomfort that comes with that. So the burning comes from UV exposure. So what we can do to try to get a dose of sunlight, or maximize the dose of sunlight without necessarily risking as much UV exposure, is to try to do it in the off-peak hours when we're not getting the UV, which is going to be in the morning and at night, where we're getting predominantly red, we're not getting UV, and then we're able to take in as much of that light as we can without getting burned, which is nice. It's also a little cooler, a little easier to handle for some of our POTS folks. But then trying to get in the middle of the day, being able to get a little dose so that we can get some of that UV exposure, stimulate the skin, stimulate the melanin, so that we can drive those processes as well, which have a lot to do with detoxification. When you think about absorbability, things that have high melanin concentrations are very good at holding on to heavy things like metals, like molds, so that allows us to be able to help in those detoxes. A lot of people don't talk about that, but if you're someone that's trying to do a little detox regimen, sunlight becomes a very important part of that, because of not only melanin in your skin, but also neuromelanin, neuropsin. Neuropsin is also kind of like what makes our motor system work. Our dopamine system is built on this neuropsin, or in the substantia nigra of the midbrain. So it's beautiful. So sunlight has like a way bigger role than we usually think to give it. But if you can, it's kind of like as much sunlight as you can get tolerably is probably a good idea for most people. And it might take a couple seasons for a lot of people to start even getting tolerant of the sun. I see a lot of people that, like in that first year, they can go in the sun and they get zero change in skin color. They get zero tan. You wouldn't know that they were even in the sun. They're more likely to get burned, so you got to be more gentle with the exposure on the UV side, just a couple minutes at a time. But then in the next season and the next season, you'll see that starts to change and they can darken their skin and they're able to tolerate sunlight. It's really interesting. Definitely, if you're interested in that, there are a lot of cool resources, but there's a whole lot about sunlight that's super useful for humankind, especially in terms of energy production. Sun and energy, go figure. All right, what do we got? Okay. Matheson asks, another good question. Can abdominal vascular compression cause cerebral hypoperfusion? Okay, so let's walk through that a little bit. I got away from keeping up with my chat. I'm way behind. Okay, I'll do my best here. Okay, so vascular compression. So vascular compressions can happen. The most common one that people will know about and they'll talk about will be the arcuate ligament compressing the iliac artery. So basically the diaphragm, as it comes off the anterior component of the lumbar spine, if we change the positioning of that lumbar spine, sometimes we'll find that ligament becomes compressive. And some people have these just kind of like weird hereditary things where we just get little different formations of how they work, and sometimes they can become compressive. When that happens, that arterial system will be blocked a little bit. It's harder to push the blood flow down. And people will talk about that a lot as a catalyst for, they'll do that surgery in hopes to help with the POTS. It's interesting. I like the idea of removing compression. Also, we kind of think about, well, that's affecting like outputs to the lower splanchnic system, and then how does that really affect the return of the vasculature? Are we catching some venous supply in there as well? So in short, anything that obstructs blood flow we don't really like. It's gonna, especially that one's gonna cause a big sense of palpitations in the chest because of the restricted blood flow. We're gonna see changes in GI function. People tend not to do as like obviously dietary things because we're altering the perfusion to the gut. But as far as like, does it directly cause hypoperfusion? Not directly, but it can indirectly cause it as a way that we're trying to compensate for changes in blood flow in the splanchnic system, and then affecting venous return back up to the heart. But it'll cause a lot of congestion also within the system, which isn't ideal. This is a bit of a controversial subject in the field because of that, because of kind of that I don't know nature of the degree to which it's causing the oscillating flow. What is useful is when people do see that we measure with the ultrasound and that artery is a little bit compressed, what I do like to look at is the position of the lumbar spine, and if we have enough of a lordosis or enough of a curve in that low back and enough of a tilt of the pelvis. And what you can do is, while you're measuring that, a lot of times it's laying down or on their side, you want to also access that lumbar curve and see if it offloads that arcuate system, because sometimes we'll misdiagnose it, and what we think is the ligament as the problem. It's actually the position of how those vertebrae are relative to each other and relative to the diaphragm and that compression, and then actually creating that lumbar curve. People will notice it's easier to breathe. They don't feel as much of that pounding in their chest, and then with the ultrasound, they can see that it'll open up that arterial structure. Not for everybody, but it's definitely, like, if that's the difference in being able to do some lumbar hyperextensions and get your back a little stronger, might be nicer for some people than doing the surgical component. So good question. Thanks for asking that, Matheson. All right. Keep rolling on. I'm thirsty tonight, so I'm going to take another drink of water. Let's check in with everybody. Thanks for being here again. As always, I see some new names, which is always really fun. Let's see where we're at. Okay. What do we got here? Sasha. Welcome, Sasha. Have you had success in relieving symptoms related to heat intolerance? What is the underlying cause that creates the heat sensitivity to heat as well as fatigue following heat exposure? This is a really good question. This is the time of year we're getting this one a bunch. There are a couple questions in there. So number one, can we relieve the symptoms? Number two, the underlying cause of the sensitivity to heat, but as well as the fatigue. Now, a lot of people will get fatigued generally in the heat. That's just the gift that is the heat. That's what, picture, lying on the beach. Most people aren't energized by that. But our POTS folks are people that have difficulties with different types of perfusion will be more sensitive for two reasons. Number one, if we have reflexive problems with being able to maintain enough blood flow to our heart and to our brain that it's given us symptoms, taking more of that blood flow and pulling it into the skin to manage temperature takes it out of the budget, makes it harder to be able to perfuse the brain. So that's number one. Just pushing it into the skin with heat, doesn't even have to be sunlight. Heat, pulling that redness or that blood flow into the skin can make some people just feel like their battery gets drained, right? And that's pretty common. So that's number one, is that we're already looking at a system where the blood flow is not managed well. By pulling it into the skin, we're just not helping the situation. It doesn't mean that is the problem. It just means it's not going to help. It's going to make it worse because it's going to exacerbate it. It's going to be a stressor. Now, the second part is that with different types of dysautonomia, and it's not everybody, but to a degree, we can also see all these feedback loops become impaired where we're getting changes in sensory afferents. So somebody might be more sensitive to their world. They might be less sensitive to their world. They might notice that their body is more reactive. They might notice that it's less reactive. But all of these things have an effect at the cerebral level where we create that picture of us. We drive that into the paraventricular nucleus that then goes down and distributes some of those like energy producing systems where we're trying to increase energy exposure. So that's increasing metabolism, that's affecting sympathetic outputs relative to blood flow, kind of all these things. So if we change that though, and we see that the signals aren't as clear, we take something that's usually like a nice tight rhythm. Where's my camera? A nice tight rhythm. And then we start to expand it. So it's almost like if you have somebody where, like in your home, if your thermostat isn't sensitive enough, you might have it set at 70 degrees, but it might be like 74 before it kicks on to cool it down, or it might be like 65 before it starts to warm it up. So you see this bigger fluctuation in what can happen before the sensor kicks in and solves it. So for a lot of people that have POTS, we do see where not only baroreceptors have a problem with having quick sensitivity, that we'll see that relationships of the PVN or the paraventricular nucleus will also have a harder time with all of it. So sleep sensitivity starts to change, hormone regulation starts to change, glucose is a little less stable, pH is less stable, and then our ability to control our thermostat is less stable. So today we were just talking about this in the office with someone who was noticing that yesterday was having we get hot and then cold, so we look over, sweaty, and then blanket, sweaty, blanket. And like trying to manage that was hard. She's like, I'm assuming that the office isn't changing temperature in any major way, and it's not. But as her system is strained or pushed, then it has a harder time being able to manage those. I even had one case years ago that was a head injury where she had a slip and fall and had a big extension injury. And she would notice that if she laid on one side, she would get super cold, like in bed at night. Laying on one side, she'd get really cold. But then if she rolled over to the other side, she would just take the blankets off and she'd be a pool of sweat. And she worked on this a lot because she thought, well, maybe it was just like the oscillations. but she could reproduce it in one side, and she could change it back and forth, which is really interesting. And that was like a big clue that solidified and stamped into my world how important it is to look at the way that your body is able to signal to your brain, not just in feeling your body, but being able to control all these automatic outputs, including temperature regulation, which was a big eye opener for me early on in my professional life. So the question is, can you help people? Yeah. If you can solve for the underlying, a lot of the heat intolerance stuff goes. It's actually really fun to watch because it's cool to see people getting back outside again, being able to sweat, being able to enjoy the sun. But there is some behind the scenes of like what is causing that becomes helpful to actually be able to solve it, rather than saying I'm just going to target the heat part. Okay, another good one from Mathieson here. Let's see where I'm gonna check on some comments. Mary Turok says, I need to put a reminder on my calendar to tune in on time. I appreciate the weekly sessions. Thank you for saying that. Dr. Ginia will call you out. She'll just give you like a little wake up call like they do at the hotel, nice soft voice. Appreciate that. What do we got here? Just some comments about wedge pillows. Julia, let me see. I think I missed a little component of this. All right, I'm gonna back up. I'll answer questions again in just a second, but let me back up here. Julie was saying, I think we were talking about PNES. My videos say they can overlap, just separate conditions that are interconnected. In Australia, there's a big focus on Western medicine that we're behind. What you're saying is what I agree with. That's really kind of you to say. I appreciate that. I agree with you that language is tough and it's annoying because sometimes people will create Edwards out in the UK went through this huge undertaking to move psychogenic movement disorders into functional movement disorders, and creating inclusionary criteria, published all the papers, went through, Stone was part of this as well, went through this massive work to be able to say, hey, I get that there's a psychogenic movement disorder thing, but then there's also this thing with FND where we can have these inclusion criteria that allow us to say this is that, and then using that helps us to be able to treat it, rather than saying it's not any of these other things, it must be psychogenic. So in that same way, when we have all these language, they get kind of confounded with each other, then it's hard for people to recognize them. So with PNES versus POTS, I actually really dislike the diagnosis of POTS. I think it's a silly way to name it, but it's a thing that is very easy to understand in terms of your heart rate. People can measure that really easily. They can feel it, they understand that that's going on, and it's easy to talk about and to express. But as far as describing what is happening, I think it's a terrible term, and I think it actually leads a lot of people in the wrong direction. And I think the same thing is true of non-epileptiform seizures and seizure-like events and all of these things, because it ties it to this word seizure, which it's not, because the seizure is categorized by the fact that we get a change in the EEG wave. So by calling it non-epileptiform seizures is kind of saying like it's not really that, but we're not describing what it is, which makes it really hard and leaves people feeling like it's in my head, and then they, obviously, as you know, they feel left out of that. And so you mentioned here, my integrative practitioner thinks that I have PANS, which leads to POTS and epilepsy. I'm not sure if you know about PAN and PANDAS. It's not well recognized. Yeah, so these are post-strep types of syndromes where we just see the strep goes up into the basal ganglia, which is what I was describing earlier, and that's why we see these changes in the movement disorders. It's not different from what we see with different types of clonus or different types of coriform movements, but we're doing a disservice for people because we're not explaining it very well and differentiating it from kind of the common things and giving them their own their own language, their own diagnostic criteria, their own inclusionary and exclusionary criteria. So I think that that's really important. That's part of why we talk about POTS in this way, is because we want to say we got to not go from symptom to treatment. There's this middle part that is the most important part, where a symptom is like, you should talk to somebody about this, or something up. And then that should lead us to like, what is going on? What is the mechanism? And then that mechanism then opens the door to the matching treatment, right? So there's this linear feature that we're skipping the mechanism part, and we're going symptom straight over to treatment without knowing what the mechanism is in between, which is going to cause us to miss a lot of times. So sorry I'm taking that out of order, but I think that's really important because it persists not just in PNES or POTS, but in this whole world of things that you can't see well on an imaging file, you can't see well in blood work, but it exists in a ton of people. All these people with concussions and whiplash and injuries and viral injuries, all this stuff where people on this stream, they're just getting kicked to the curb, and there's absolutely no reason for it. So I've got a little bit of passion for that, and I apologize. Okay, back to questions. I'm sorry. Matheson asked, if treatment helps temporarily, how do you determine if it's because it's helping with the vestibular system or relieving compression on the vein? You got to measure it. So here's where a couple things. You can do advanced diagnostic testing where you're looking at ultrasound. And at ultrasound, you can see if we're still compressing the vein or not. That's a great one. And then you want to do that in provocative positions and in neutral. So straight away, and then in these provocative positions. Sometimes that's not as easy to do, but what you can look at is looking at peripheral venous pulses. You're not going to be able to see it as well with everybody, but for a lot of people, you would be able to see them in the actual drainage, where you'll see the pulse change in the neck if it's being compressed. You'll want to look in the pulsation of the fundus, looking in the optic disc. You want to see if there are pulsations that happen. This is one that we looked at today, where we had a TOS case that was considered a vascular TOS case, but it also was vascular TOS case due to a shoulder injury, but also it was a C8 radiculopathy, and those two things overlap like crazy. So they were just kind of missing it. But one of the things that we were looking at was, can we put in those positions where we cause the problem or the symptom, and see if that venous pulse is evident, see if it causes back up into the venous system, and then understand how that overlaps. So that can be really helpful. Number one, measure the venous output. You can do that through advanced testing like an ultrasound, but you can also do it with bedside testing as well, looking at positionality and seeing if we're changing the venous system. That's number one. And then if it's affecting the vestibular system, then you want to be able to do the same thing. So can I measure changes in occluded vision or the ability to hold gaze, or are we having nystagmus? Do we have intact VORs? Is it a cervicogenic problem? Well, we're measuring that, and what we want to do is measure them both side by side, and the hope is that you may have some degree of both of them that are going on in a lot of cases. So you're saying, can I solve for the vestibular thing and those symptoms go away? And then in the same context, can I now structurally move around because I've got a cleaner movement pattern in a way that doesn't cause that vascular occlusion? So really good point. By being able to combine and think of them at the same time, you can know to what degree you're affecting both symptoms, and you should, which is really cool, especially if you've got some ultrasound available. That can be really helpful. Great questions again. I love it. Okay, I didn't see who this was from. It says, I had dysautonomia resolve after a whiplash and being treated by a chiropractic neurologist. Can you touch on this topic? Absolutely. Number one, I love that it's resolved. That makes me very, very happy. And number two, love that a chiropractic neurologist help you on their game. I love it. In whiplash can be a big factor in people experiencing changes in autonomics, either up or down, right? So causing blood pressure to go up, blood pressure to go down, heart rate to go up, heart rate to go down, et cetera, et cetera. One of the primary reasons is all of that information is traveling through your neck. You have inputs that are traveling outside of the spinal cord that come up and affect the neck through sympathetic and vagal nerves, right? So those are both wildly autonomic. We see that we have the superior cervical and inferior cervical ganglion, nodose and jugular ganglion that are in the neck, again, carrying this autonomic information, for lack of a better word, sensory information. And we also have the spinal cord and the peripheral nerves, or spinal cord and radiculopathies that come down and they're transmitting those signals as well. So if we have problems where we create stenosis or we create injury to the nerves here, then we're going to have problems. But also if we create proprioceptive error in the neck and we create central vestibular error that helps us to integrate eyes, ears, neck movements, then we can see, independent of actually injuring the tissue in the cord or in the neck itself, but just impairing the motion or the sensation of motion, that can also cause these autonomic problems. So your neck becomes super important for the autonomic system because of those reflexes. So if you have someone that's keen and understands that, then being able to solve those problems, just untangling that knot, can help resolve the dysautonomia in a lot of cases. You hear people talk about craniocervical instability. They talk about using upper cervical chiropractic. These are all ways that we're trying to unwind that knot. And if we happen to hit that ball square in that area, and that is the problem, then it can have a huge unlock for people. So I'm hugely in favor of that, making sure that your neck is in really good shape and that it's moving well, that it's positioned well, and that we can kind of cross that off the list of things that are causing the autonomic problems, or fix them up good as new. Christy Lee. Oh, that was from Dance Diva. Thank you for asking that question. That's a really good question. I love it. Really good question. Christy Lee. Some people say there's a correlation between hypermobility syndromes and dysautonomia with neurodivergence. What do you think about this? So neurodivergence, in terms of kind of thinking about people that are on the spectrum, so think about it simply. We started the day talking about, as we kind of move toward the end, we started the day talking about people that had ischemia at birth, they get cerebral palsy, and then later on that develop stroke, which is also another form of blood loss to the brain, and they both end up in these scenarios where we affect outputs. What we're now calling neurodivergence, which has had other names in the past, we're talking about people that have changes in brain function, just to keep it simple. And that brain function is causing different outputs and inputs into that system. So it may make them more sensitive to certain things, it may make them overwhelm easier, it may make them less sensitive to where they don't respond as well, or they're hypo-responsive. And then same thing on the other side, they might be hyper, they might have, for a given input, they might have too much output, or for a given input, they might not have enough output, right? So that's like the classic description. So if that's true, then anything where we're looking at tone, so one of the things that we know from early childhood development is that when we see people or kids that have problems with brain development, they will tend to either have more spasticity in the musculature for central problems, or they might become hypotonic when we see problems in the posterior portion, the lower portion of the cerebellum. So that tone of the muscles is going to be kind of displaying what's happening in the brain. So you'll see that also in neurodivergence as they get older, where you might see people that kind of have different postures or tightness in their muscles, or they walk on their toes, or we might see them be really floppy where they don't have a lot of muscle tone. And in those cases, we're more likely to see them where they're going to have mobility challenges because their ability to have proprioception of the joints is impaired, which means you're going to have more mobility than if those joints were tightly controlled. So they're not, again, we use the road analogy. If you have a high level of input and tuning, you're going to keep it between the lines really tight. So we're able to control it a lot more with the musculature. If that's not getting in there, then we may fall off into the ditch a lot easier, which means we're going to see more on the hypermobility side. So that's one part of it, is you're looking at the relationship of hypotonia and neurodivergence, which is a strong overlap. And then the second part, I lost the second part. Christy Lee, where'd you go? We were talking about neurodivergence affecting, oh, here we go. hypermobility and dysautonomia. Okay, so the second part is the dysautonomia part. That part should ring true pretty confidently for a lot of you, because you'd think we talked a ton about how much the outputs of your brain are going to control the integrity of the autonomic outputs, the autonomic system. So if I can, again, same thing, hyper or hypo, it can go both ways. If I'm not sensitive enough to my environment, I may see that I don't respond as well. So the same way we might see someone with neurodivergence might have orthostatic hypotension, where their blood pressure is really low, they're passing out. That's super common. We also can see where it runs the other way, where not only do we see POTS, but we might see inappropriate sinus tachycardia, where the heart rate just screams along all the time and they just maintain that high heartbeat. They may not even notice that they have symptoms or problems with POTS, but they might just sustain a high heart rate. Whereas other people may notice that it is responsive to orthostatic problems, and we may see vestibular or visual problems with that. So the same way you might think about a stroke, or you might think about post-concussion syndrome, we can also think about that in terms of neurodivergence or childhood developmental disorders, where that change in the integration from the brain is going to affect all things downstream of that, including autonomic systems and even including what we think of as structural things in hypermobility that may actually be more relative to muscle tone and hypotonicity. So that's a really good question, but it's a good reminder of how these different neurological conditions, even though we get them in different ways, they affect different parts of the brain, but we can see that they have similar outputs in terms of what we see symptomatically. So Christy Lee coming through in the clutch as always. Well done. Okay, let's do this one more. Oh, Ginny said Corey just jumped in. Awesome. Hey, you know what? I'm glad you're here. Also glad you were out partying, burning the midnight oil tonight. So glad to see that as well. Glad to have you in. Sasha asked question 2. Is it better to visit your office at your best or worst day? Summer for me. Talked to someone at your office about a visit, but forgot to ask this. Yeah, that's a good question. I personally will try to get to what is the worst part. So if I can see you at your worst, then I know I'm not missing anything. So remember, I'm seeing people every day that I am like interloping into their life. Like they've been dealing with this thing for a while, whatever this problem is. They are intimately aware of it, and I am coming in late trying to catch up, right? So I'm trying to get as much information as I can to understand your life as fast as possible so I can catch up. So sometimes being able to see you at your worst, that's my best time to be able to see what is the full scale picture here. The second part about that is I really love when somebody feels bad and they're like, maybe I shouldn't come today. And I'm like, you should for sure come today because I'm going to try to fix it. And those days are really awesome because we can see if we can take people from feeling like absolute crap and see if we can scale them back up in that day and use that as a teaching tool to say like, well, if we can get you from here to there, like we can see how these things affect your life. And then it makes it easier to be able to continue to do them and then to recognize like I'm having a bad day. But also, I remember when they were doing that thing in the clinic, like I got out of it really fast. Let's keep doing those things. So I like to use those bad days and turn them into as much good day as I possibly can. So, and then see what's the worst thing. A lot of people are nervous they won't have their worst day while they're here too. They're like, I'm having a really good day today. I hope you get to see what you need to see. And but either way, we get our measurements. But I'm always happy to play as it lies. But if it's a bad day, let's take a look. Let's see what's going on. So hope that helps. Corey can't turn down a good party. I love it. Corey's wild. Corey's a wild man. Motorcycler, inventor extraordinaire, most interesting man alive. I love it. Okay. Hey, this was awesome. If you guys wouldn't mind, let me know. I'm trying to keep up with the comments a little bit more. I don't think I nailed it, to be honest with you. Because I missed some of these comments, like Rob, for instance, saying he doesn't seem to get burnt out for a walk for 30 to 40 minutes at a time. Sounds like I should walk around topless as much as you can. Do that for the ladies, for sure, but also for your own skin health. Just work on the callus. If you start getting burned too much, take a little off. but my perspective, and people disagree with me like this like crazy, I have a strong bias for this. We could probably talk for a couple hours about what I think, but generally speaking, I think sun exposure is good, especially for people that aren't doing very well, to help to get some of that energy demand. People talk about mitochondrial problems. Sunlight. So anyway, we're closing in. It's time. It's probably a good time to wrap her up. But thanks again for being here. Awesome questions. I really, really appreciate it. We've been able to actually take some of the questions and kind of cut them and put them on YouTube, which is really fun because then we can categorize them. So if you have we cover kind of a range of things here, but if you have a certain question, being able to search it on YouTube and get like that little snippet is pretty helpful. So I'm thankful that we can do that, and we'll keep trying to do that as much as we can and more, just to share, help people get some perspective of the way we're thinking about it. And let's keep inviting more people in. Let's keep inviting more physicians in. Let's have good debates and conversations, and that will help us to be able to kind of let the best ideas win. And that's what I'm in favor of. So I'm excited. Thanks for being here, guys. Really, really appreciate you. I'm looking forward to the next one. I'll see you next Thursday. Go get some sleep.